It's also Happy Awareness Week. And if you know a bit about Happy and the design principles, one of the key features of Happy Designs is around care readiness. And that includes the adoption and the deployment of technology to support people independently in their home. So again, it's really appropriate that today's and this afternoon's session looks at that in terms of both smart homes, but also the smarter thinking that we're all taking forward and actually have had to take forward as a result of COVID. So I'm delighted that we have this session, and thanks very much, Zilla, for chairing, and I pass it over to you to take on the chairmanship for the rest of the session.
Thank you very much, Jeremy, and thank you to Housing LIN for giving us this opportunity. We're really pleased to be able to support the conference, and I'm really happy to be involved in it. So just to introduce myself, my name's Zilla Moore. I'm the Marketing Director with Tunstall Healthcare, and I'm going to be chairing the meeting today and taking you through an overview of the technology solutions that Tunstall provide before handing over to two experts who've actually been using our solutions in practice and making a difference where it matters most. So basically, if you don't know a lot about Tunstall, we've been around for since about 1950, I think. Basically, we were the first company to introduce a ward and call system for elderly people in sheltered housing, which enabled them to call for help if they needed it. And since then, we've been very active in the both in the independent living space, which is about putting social alarms into people's houses to allow them to live a more fulfilled life at home, but we also provide solutions for people who live in community living scenarios. So that could be sheltered accommodation, it could be assisted housing, it could be retirement homes, and that's probably the main bulk of Tunstall's business and what we've been known for a long time. But we also have other solutions as well. So we're very interested in pursuing the telehealth and telemedicine field as well, around remote patient monitoring, which is really supporting people living with long-term conditions and chronic conditions to live at home and to be health monitored at home, so that they're not so much having to go back and forwards to their GPs and to primary and secondary care. So that's quite an overview of what we do. In terms of this very, very strange year that we've had, I think the pandemic has definitely, upended our whole world in some ways, and it's really changed the way people view technology. So whilst it's created a huge amount of pressure on both the NHS and the social care system, particularly care homes, it's also kind of forced an adoption of technology that probably would have taken a bit longer otherwise, particularly when it comes to solutions like remote patient monitoring in the NHS. And I think the other interesting thing that it's done is it's dispelled some myths about older people and technology as well, because I think there was always this myth that the older generations weren't comfortable with tech, and actually you've got grandparents quite happily Zoom calling their grandchildren now, and I think it's kind of opened the doors to the fact that people are much more open-minded to the adoption of technology. So basically, I'll be talking to you through a little bit more about what Tunstall do and the solutions we provide, and then I'm going to hand over to Joanna Dorsman, she's from Bolton NHS Trust, and they rapidly deployed one of our solutions to remote monitor residents in care homes and allowed them to basically manage a huge population relatively safely during the pandemic, where they could monitor their health conditions without having to have them go into hospital or go to a GP surgery or have the GPs and healthcare staff enter. And then followed by that, I will hand over to Sarah Weist from Nottingham Community Housing Association, and they work with Tunstall and utilise our monitoring software with their smart team, which Sarah will tell you a little bit more about. And they use that technology to support a much wider community than would normally be associated with dispersed alarms or emergency alarm systems, both in independent living scenarios and in group living scenarios. So I'm going to let them tell you about how they manage that on the field, because they're much more expert than I am. But if you bear with me a minute, from a technology company, I will attempt to share my screen. Hopefully you can see that. Excellent. Right, I'm actually at the end of the presentation there, so let me go back to the start. So I wanted to talk a little bit about winter challenges and the difficulty that this presents. And I think it's fair to say we're probably all agreed that this has been a quite exceptional winter so far, and we're still not through it all yet. But if we think about winter challenges, it causes a huge amount of pressure for both the NHS and social care systems, even in a normal year. So you have a huge number of people living at home with long-term health conditions. They would account for, in a normal year, would account for around 70% of bed days in hospitals. They use a huge amount of NHS resources, as you can imagine. And often they have comorbidity. So you very rarely get somebody with just one thing going on with them when they've got a long-term condition. Often they have a lot of comorbidity. They might have diabetes, which might also be linked to heart failure. And that also presents itself with the challenge of living with a long-term condition. Often these patients have mental health challenges as well. And then you look at people who live in care homes. Huge amount of people in care homes suffer from dementia, and there's been a big increase in emergency admissions over the last 4 years for care homes. And this group, particularly during the first wave of COVID, were really significantly impacted. So if you think about that's the normal pressure in the NHS, and then you add in the whole pressure of COVID-19. So you've got these highly vulnerable patients who need to be, and individuals who needed to be shielded. You suddenly have higher risk associated with hospitalisation. You have hospitals that need to clear their beds to cope with the influx of COVID patients, so huge pressure on the NHS. Cancellation of routine appointments. You've got all of that adding additional stress and higher risk. And then on top of that, you've got winter in general, which is, that's always associated with winter conditions like norovirus and flu and everything else. So all of that together was right back in the summer, all the healthcare professionals were anticipating this was going to be a really challenging winter. Just to go into a little bit more of a kind of detail about this. So the normal problem with people in care homes, in NHS setting and in hospital, is that it's actually the time to get them out of hospital. So hospital discharge has become a really big problem and a big challenge for the NHS during this particular winter. It always is, but this winter it's even more difficult. So around 5% of beds are blocked at any one time in a normal year. That's without COVID adding to that. And then about 5,000 patients staying longer than is necessary. And the interesting thing there is the reason that they are staying longer is that there's often not a care package for them. Waiting for them in their own home. So the real challenge for the government and for the NHS is to be how do we enable a more efficient hospital discharge to be able to cope with what we anticipate is going to be this very difficult COVID winter. So this is why the government recently, or the NHS, published new hospital discharge policy and operating model and put a huge amount of money behind it as well. So this has been rolled out, and really it's looking at how do we more efficiently discharge people, but the key thing here is safely discharge people from hospital to make sure they're still cared for in the community when they get out of the acute setting. So there's funding available up until the end of March, and that supports post-discharge for up to 6 weeks once somebody's left. So reablement services and discharge is a real part of that. In terms of the rules that apply to that, so the mandate is discharge people as soon as possible today. Any further assessments try and do in the community. Discharge to assess is default, so that's what you should be looking to absolutely do. Discharge to home is the default, so that's wherever you can, you should be discharging to home. Community health providers and social care will operate with a single coordinator in the acute centre. The CCG and local authority commission separately. If they do, they'll establish a lead for joint commissioning. And the interesting thing from a Tunstall perspective, and for this discussion, is expand the use of telecare and telehealth where possible. So I think it was recognised that this was an important way that we could support getting people out of hospital quicker. So just a little bit about the different technology solutions that Tunstall offer, which are some of which are being used in this setting around hospital discharge, and a little bit about Tunstall. So our vision is to help build a world where people have the freedom to live life to the full in a place of their choice. So it's all about keeping people independently at home or in a community setting where they can have the best possible quality of life, making that journey as long and as comfortable and as quality of life as we can, basically. And we do that by providing technology-based solutions. Not just that, but we also provide services, and that's about streamlining our customers' ability to deliver more efficient and effective models of care, which I think the next two speakers are going to demonstrate really, really nicely of how that's done in the community. And then where we're going as a company, so those of you who are familiar with Tunstall probably know us very much as being a company that supplies telecare alarm systems, whether in somebody's home or in a community setting, and that's what we describe as reactive telecare. So that's where we provide the equipment and sometimes the solutions and the monitoring to allow reactive telecare monitoring. So if somebody has an emergency, they can press one of our alarm systems, and that will go through to a monitoring centre where somebody will be able to deal with that issue there and then. But we know that as we have an aging population and as people are living longer with lots of more comorbidities, that becomes increasingly more difficult, and the cost to society is a real challenge. So what we're trying to work to facilitate with working with customers like Sarah and Joanne is really to move from a reactive scenario to proactive. We get this a lot in our telecare facilities in Spain, where we actually, and Sarah will tell you a little bit more about this later, this is where rather than just having reactive telecare, we're actually proactively reaching out to our service users to support them in the community to try and help prevent them ever needing to press an alarm. Then we move towards predictive. So this is where we start using our technology in a smarter way to gather information, which could be information about a particular healthcare condition, or it could be information around activities of daily living that helps us build a pattern so that we can start to tell if somebody's disease is deteriorating or progressing, or if their pattern of behaviour has changed, so that we can predict that a potential emergency before it happens. So a really nice example of this is where we're looking at ways in which we can predict whether somebody with COPD is likely to have an exacerbation and need to go into hospital. So we can try and we can enable physicians to intervene before that. And then the very, very final step of that, which we call Tunstall Cognitive Care, is bringing all of that information that we gather from all our hardware and our software and all of our customer systems together to be able to build a population-based picture of health and social care needs, so that we can be supporting our customers to make the right decisions about the most at-risk populations within their catchment area, and also we can be trying to empower our patients and service users to be much more involved in their own healthcare. So one of the things we're looking at doing is how do we use remote patient monitoring to engage diabetes patients with type 2 diabetes. So instead of being something that we just monitor a disease, we're actually empowering the patients to try and take control of their condition and potentially reverse type 2 diabetes or manage it more effectively. So these are all the kind of things we're working with customers around the country to achieve. So just move on. This is where all our products come together. So this is where we talk about integration of connected health and connected care. So connected health is really about remote patient monitoring. You're going to hear a lot about that in the next few talks. And then connected care, again, is about providing that reassurance and security through response centres 24/7. And we have a whole bunch of different products that span that space. And the interesting thing is with digitisation, all of that's becoming closer together, and we're being able to share the information between connected health and connected care a lot more efficiently, so that we can make better decisions around our population, around patients, help support our customers more. Just to give you an example of our connected health products, so we have a product called Triage Manager. So that is a web-based portal that a clinical team can log into, and they'll be able to see information about all of the patients in their community that they manage. And they'll be getting regular updates about the patient's condition. And the way we do that is we provide the patients with access to the system as well through an app that goes onto a mobile phone, or to a smart device like a tablet that goes onto that can manage multiple patients at once. So if I look at the app-based solution, if I was a patient, I would download the app onto my iPhone, and every now and again, or every week, it would ask me a series of questions about my vital signs. So if I was a diabetic patient, I would be recording my blood glucose levels, for example. I might be recording my pulse, I might be recording my heart rate, I might be recording my weight. And it would also ask me some questions in a questionnaire around how I was feeling and how I was generally managing with my diabetes. That will then go into a very smart piece of software which risk stratifies me based on the information I've given. And if I breach any of the preset parameters that would flag as a risk, then when my physician logs in at the other end, they'll be able to see that I'm potentially a more high-risk patient. So I will come up as a red patient rather than amber or green, and that will tell the physician that they probably need to get in contact with me, invite me to a clinic, or maybe make a video call. So that's kind of how the mobile version works. And then my kiosk is a similar thing, but it goes into multiple group living scenarios where a care home manager or care home staff can collect that information for a whole bunch of their residents, and then the clinicians team, or the clinical team, will be able to log in and see how the residents are doing, basically. And Joanna will tell you a lot more about that in a little bit. In terms of independent living, we have two main products that we support people at home with, and this is our analog alarm receiving system, which has been around for a long time and is probably the most prevalent in the market, and also our new digital system ready for the digital switchover in 2025. So these are the systems that go into somebody's home, and if they have an emergency, then they can press these alarms, and it will go through to one of the many monitoring centres in the UK. Basically, we also have other products as well. So I don't think the graphics have come up for this, but basically we can have a number of peripherals that speak to the monitoring the product. So basically, if somebody has a fall, that will be detected and it'll ring an alarm. Somebody can wear a pendant, so if they're not actually in the house and they're not actually next to the hub in the house, if they're down the bottom of the garden or whatever, and they have an issue, they can also press their alarm and it will go through to our monitoring centre. We also have some other interesting products that we released actually due to COVID-19. So back in the spring, there was a real need for people who probably don't need a telecare solution per se, but were potentially a shielded part of the shielded population on their own, just needing some kind of reassurance and some way to call for help, or somebody to check in on them regularly and signpost them to services if they needed it. So we designed an app called Tunstall Connect. It links to our monitoring centre, where we monitor quite a few, about 100,000 patients at the end of it. And if somebody wants to download this app, basically they can press I'm OK at any point every day. If they don't press the I'm OK button, somebody from our monitoring centre will proactively call them and check that they're OK, and then also point them to any services that they might need. So that was really designed, it's not necessarily a telecare product, but it's really designed as a wellbeing app, so that somebody who was shielded or didn't have access to their normal support network or services could call for help, or could just be in contact with somebody if they needed it. And then in terms of our group living, we have two main products. Again, we have an analog version, which is our Communicall VI, and then Communicall VIP, which are products that go into either assisted living or retirement homes, or retirement villages, and basically they allow connectivity throughout the whole home, and they allow the residents to call a warden or call a concierge service. And this is probably one of the most rapidly evolving pieces of our equipment, and one of our most rapidly evolving solutions, because that retirement living space is changing so much. So we're increasingly looking at more digital solutions, which will allow a lot more kind of community and interaction between residents in a communal living scenario, and it will allow friends and family to also access the residents as well. So there's a huge amount of investment and development going on in this space. We also have a really interesting in terms of what COVID did. So we had a product that was developed in our Norwegian business, and it was really a nurse call system that was based more on the residents than it was on the building. So traditionally, nurse call systems have been installed, and where a resident in a care home has an issue, they'll press an alarm, and it'll sound the alarm throughout the care home, and the nurses will come and deal with the issue for that resident. This system's much more subtle. It's much more person-centered. So there are a number of sensors in each of the residents' rooms, and then each of the carers has an app on their mobile phone that's linked to the sensors. So if a particular resident has an issue, they can actually trigger the alarm without it sounding throughout the care home, which made a big difference for other residents who then weren't being disturbed. But also it allows the carers to be able to accept, if there's a carer nearby who's free, they can accept that call and go straight to that resident, or they can assign it to one of their colleagues who they know is free if they're busy, so that somebody always is able to deal with the resident in a very, very subtle and very personal way without alerting the whole of the care home. And we did have care homes that had initially installed this system for that very reason, but actually they also started using it to create COVID bubbles during the pandemic, which allowed them to have care bubbles that particularly supported certain residents and really enabled them to manage the infection rate very efficiently, because it also geofences the residents as well, so we can separate residents and protect them with the support of this system. So that was quite an interesting development of how this product was used in a slightly different way because of COVID. And this is just an example of how CareCom was used in these bubbles. So it was at Parkview in Halifax where they actually came up with the idea of creating a kind of a infection safe care bubble, and at the time when we did this case study, they'd had no infections at all. They'd managed it really successfully. So it's something that other customers are now starting to install and looking at how we can use these kind of solutions to not only give a more person-centered approach to residential care, but also protect residents if there's in an infection scenario. So that's kind of I've rapidly whipped through all of our products, and some of them are quite complicated and some of them are very simple. But I will ask you to maybe leave your questions to the end. By all means, type them into the chat box. But if you, there'll be a session at the end where you can ask questions. But I'm now going to hand on to Joanna, who's actually going to talk about how our health system, My Kiosk, was deployed across a number of care homes in Bolton in really rapid adoption during the first pandemic.
Okay, thank you so much, Zilla. Thanks for handing over, and thank you so much, everybody, for listening and welcome. And thank you to Housing LIN for inviting me along this afternoon to speak. And as Zilla has already said, I work in Bolton. I work for Bolton Foundation Trust, but I actually work across Bolton Integrated Care Partnership. My role is around integrating health and care services in places, in neighbourhoods, working with communities and a range of providers from housing and from the voluntary sector. So my role really was particularly relevant and useful within the care home support package, because I was able to bring health and care support in. We quickly recognised, I think, alongside the national picture of the vulnerability of our residents, and had some initially very high positive rates in some of our larger homes. So we had a real need to respond very quickly. Okay, next slide, please, Lois. So we had a number of initiatives already in place, really aiming to upstream care, really trying to deliver proactive interventions to support health and wellbeing of care home residents and really to avoid admissions. So we tried a different package using video linkage the year before that was connected to a remote team outside of Bolton, but we'd also worked with Tunstall previously, but always on a single patient solution, and that was largely largely around the support of people with COPD, chronic obstructive airways disease and heart failure. So the crisis came and it made it critical that we had some technology available to really reduce the amount of face-to-face contact for the care homes. What happened was that our GPs in Bolton were using a solution called Attend Anywhere, and they were using largely video links to speak to the home managers and where they could to see the residents. But the gap was really around the observations. So it was around being able to see, did that person have a temperature? What was their oxygen saturation levels like? What was their blood pressure like? But more importantly, what was normal for that person? So what was their baseline? So what this really did was it accelerated the transformation of our model of care and how we work with our care homes. And I hope it's really changed working practices for the long term. Okay. So what is my kiosk? As Zilla has already said, it's a multi-user application. So it's software and it's on an Android tablet and it's connected via Bluetooth to a number of peripherals, which include pulse oximeter, thermometer and blood pressure monitoring machines. What we were trying to do in Bolton at the same time as probably every health provider across the country was, we were trying to source equipment for our care homes. So we recognised that ability for them to monitor their residents, to really pick up some of those early signs of deterioration was much more likely to give care home residents, because we did this at a time before we really had mass testing in care homes as well at the beginning of the first wave. But also it was proving very difficult to source equipment as well, because I think, like us, everybody was going to supply chains and trying to seek equipment, etc. So our approach to Tunstall initially was, could we potentially get some single solution devices for named residents within care homes for people who we knew were unwell. So for us, this solution really exceeded those expectations, because Tunstall provided us with something that enabled us to be much more proactive. So the data recorded by the care home staff is shared remotely with our admission avoidance team. So that's like a hub where we have a base of health and care staff. So as Zilla again said in her presentation, there was a requirement for all NHS and care services to set up an integrated pathway. So discharge from hospital could happen very, very quickly, beds weren't blocked. But equally, we had an urgent community response to try and stop people going in. And I think we recognised that was really, really important early on for our care home residents, because again, they were going in and sometimes would be COVID negative and were coming out positive, and then the care homes were very reluctant for them to go back, and how would that impact on staff and residents. So that real need to be able to respond quickly, but primarily to keep people out of hospital from care homes, was really, really important. So it allowed our advanced nurse practitioners really to pick up those readings. So we rolled it out, and again, with the support of Tunstall, within 6 weeks across all of our 36 over 65 care homes. So what we did alongside of that was we delivered training, sometimes remotely, sometimes face-to-face, socially distanced, on taking observations. So we sat with our care home staff over Microsoft Teams, and we walked them through PowerPoints of what it meant to take a pulse oximeter recording, and also the importance of temperature. But we were also by then starting to learn that actually there were different signs within care home residents that were starting to emerge. So people within care homes weren't always presenting with a temperature or with a cough, as we'd seen or were led to believe from other countries that were further on in the wave than us. It was those softer signs of deterioration. So often people would have increased confusion, they'd have a poor appetite. So it enabled us really, again, working with Tunstall, we've built in a questionnaire. So as well as part of the remote monitoring, we were able to work with the care home staff to work through that questionnaire to say, actually, have you noticed anything else about this resident that would worry you? And those softer signs, as we term them, became often more indicative of people who were more poorly and more at risk. We managed to register over 1,100 residents on the system. Our care home bed occupancy in Bolton for over 65s is about 1,400. It did drop in the pandemic in the first wave to probably about 1,200, but we were able to register most of those people very, very quickly onto the system. And June saw the first full month of usage, and there was a total of 479 sets of observations recorded on a total of 104 residents. And by the end of October, that had increased to 945. And that number, I would have expected it not to maintain on a very, very high level trajectory, because thankfully, at the end of the first wave, we did see a few months where our care homes became COVID free. So the local pathways have been adapted to incorporate remote observation readings and to reduce face-to-face visits as appropriate. And that was really important. It was important for the care homes, and it was important for the staff who felt they were going in often unnecessarily to take observations, and they use this alongside video conferencing as well. So the benefits were, it really, really did reduce the need for clinical staff to attend the care homes unnecessarily, to take observations or to carry out assessments, and therefore it had the benefit of reducing the risk of cross-infection. It also helped the capacity as well, if I'm honest. We saw a real surge in demand, as you would expect, in our admission avoidance teams, not only from care homes, but from people in their own homes. So it did reduce that time it took to travel out, to see the resident and undertake that assessment. But what it did as well was it helped us to prioritise residents' care, identifying those who were most in need of those interventions and further treatment. Because again, what we saw was that often people who were deteriorating with COVID, with this thing that we term silent hypoxia, often presented as quite well early on. So that ability to take those observations regularly for somebody when they tested positive was quite telling for us in terms of which residents and which homes we needed to prioritise for support, and indeed potentially for hospital admission as and when it was actually required. So it supported the early detection of symptoms to really enable those timely interventions, and undoubtedly did improve outcomes and helped us move more to preventative care. We also started to use it for those people within the care homes with long-term conditions who would have normally been monitored by visiting practice nurses, etc., who again were trying to reduce face-to-face contact. And it did reduce the need for more complex hospital care admissions. And what we did see overall was something like, in comparison to last year, an overall 25% reduction in conveyances to hospital and also admissions. And again, that ability to implement rapidly really enacted as a key enabler for change, but also for real engagement between health and the care homes. So the feedback from the care homes was largely positive, as I'm sure you can imagine. Staff found it really easy and quite simple to use. It was a really useful check-in for someone who wasn't well, and it increased the carers' ability to look after their residents in a holistic way. It empowered them to make decisions and know when to escalate. It able to provide greater information to GPs and clinical teams when escalating those concerns. And it really helped upskill those staff in taking observations, because we didn't just train them in using the technology, we trained them in what those observations to some degree actually meant and why they were important and what they were telling us. We used the information to upload it into their own records. So again, we had a baseline and a normal for those residents who weren't necessarily COVID positive at the time. It did reduce the need for visits from GPs and our admission avoidance team, and remotely monitoring residents over a period of time really did avoid those hospital admissions. Okay. So scalability and lessons learned. The pandemic has really engendered a willingness to change. And I think in my overall role, which is around integration, I laugh because we changed more in that first week of that document coming out about the discharge pathway and that need to have a single point of contact for health and care, a single front door in terms of our relationships with our homes, the things we thought we'd have still been meeting to talk about now, if I'm honest, we just managed to do overnight. So I think it really did help us move forward with integration right across our system. It met the criteria for the NHS long-term plan for increased adoption of technology-enabled care, and also the enhanced health and care homes, which is now a requirement contractually for primary care, but also an expectation for community services. It gave us the ability to prove the cost effectiveness, hopefully for long-term funding, and that's the point we're at now. We're trying to seek that. The system readiness to adopt tech-enabled care, really the workforce who will have to interface with the tech, but also the public. So I think there was a general willingness and acceptance now. People really, I guess, who were somewhat hesitant before, who said it'll detract from the relationships, things won't be the same. The system started to change, I think, and see the potential of technology-enabled care at a pace and at a scale that they'd really not done before. That need for continued support and training to the care home staff to support utilisation is something, if I'm very honest, is going to be ongoing. There is still a rapid turnover of staff. They have large numbers of staff in often some of our bigger care homes. So that need to keep reiterating those messages, offering that support and a point of contact at our health and care hub has been really, really key in terms of sustaining the project, and will continue to be so, really. So I think that that's really important. And we do that through a range of mechanisms, really. We run a fortnightly webinar as a partnership in Bolton for our care homes, and we always have technology and remote monitoring as a standing agenda on that webinar. And again, we get representation from all 36 over 65 homes on that, but we always welcome those contacts and approaches from care home managers and staff at any time. So a bit of a whistle stop, but hopefully it will generate some questions and hopefully a bit of discussion. But it has been an immense project that we managed to move very, very rapidly on. Thank you.
Thank you, Joanna. That was a really a great overview of everything you achieved in a relatively short amount of time. There are loads of questions, so I think what we'll do now is if we move swiftly on to Sarah, who's going to talk about how they used the monitoring software platforms and integrated that into their smart system to be able to manage a bigger cohort of service users. And then at the end we can have a quick fire round and look at all of the questions. You're on mute, Sarah. It's the phrase of the year.
Oh dear, only me. Thank you both, and thank you for the opportunity to engage in the conference today. So my name's Sarah Weiss, and I've worked for Nottingham Community Housing Association coming up for 17 years, and I manage the SMART team. So I'm just going to talk a bit about how we use our Tunstall PN system platform to support a wider cohort of customers. Just bear with me a moment. I'm having technical issues. Oh, thank you. Just a bit of an introduction into NCHA. So Nottingham Community Housing Association provide affordable housing and care and support throughout the East Midlands. We were founded in 1973 and we manage around about 10,000 homes and deliver 1 million hours of care and support each year. NCHA's care and support team work across the region to help a diverse range of people build better lives, including those with learning disabilities, enduring mental health problems, and those who are frail and elderly, experiencing or facing homelessness, escaping domestic violence, young people and care leavers. A bit of an introduction to the SMART team, my service. So the SMART team stands for Support Management and Response Team. It was developed just over 17 years ago in response to the changes in the working directives. SMART play a critical role in providing response and support to the Homes and Wellbeing's care and support operational teams across all of our services. We have currently 2,000 to 3,000 connections, some 200 which are self-funded, and work with a range of stakeholders across a wide area to help achieve the organisational vision of more homes, greater services and better lives. So the SMART response and support officers, they're all trained to handle a wide range of calls, from proactive wellbeing calls to emergency alarm calls, domestic violence incidents, and mental health helpline calls, including crisis calls, where we would need to coordinate with emergency services. The SMART team provides 24-hour support and a physical response to care and support accommodation based within our services. We use the Tunstall hardwired alarm technology and individual tailored care packages of care. We're an out-of-hours first point of contact for all our care and support service users, including a text and email facility for our deaf customers and staff, and also manages out-of-hours maintenance calls on behalf of our organisation, which delivers to over 10,000 properties. We also monitor CCTV and fire alarms on behalf of NCHA. The service also provides a 24-hour support and access to our duty manager for all care and support staff, and provides lone worker monitoring. The SMART team also manages NCHA's antisocial behaviour reporting line, and we operate a 24-hour complaints line for all our care and support customers. Just to give you a bit of an overview now into the services, our core services really that we support. So starting with domestic abuse. As an organisation, we have 3 women's refuges across 3 counties, all of which have a hardwired emergency alarm call system. Solutions are developed on a bespoke risk basis to suit the individual service user and the circumstances, which can include a bogus call button, a My Amy pendant, which can be pressed to raise a silent call to our response centre, where our operators will act according to the protocol shown for that client. This includes recording the call, sending for emergency services or other stakeholders. We also manage the out-of-hours referrals for our refuges. So during the night, we could get out-of-hour referrals from either the police, Women's Aid, or the domestic violence helpline. Moving on to learning disability. So as an organisation, we provide supported housing to over 500 people with learning disabilities, providing a person-centred care, which may include telecare systems monitored by SMART. SMART also works with Keyring, a registered charity that supports vulnerable people to live independently. Every month, we make between 1,500 and 1,800 outgoing wellbeing calls to people with learning disabilities. And this can include medication reminders, wellbeing checks, security prompts, and general how are you, how things are going. This has helped, especially during COVID, with social inclusion, isolation and loneliness. In times where funding has been reduced to austerity, many of these wellbeing calls have replaced late night care visits, waking nights or sleep-ins, supporting the privacy and independence of service users, enabling them to remain in their own home. And at times, our customers don't want people knocking on the door at 9, 10 o'clock at night, excuse me, to remind them to take the medication. So this is less intrusive. Moving on to our mental health supported housing projects. Our mental health supported housing projects, we provide out-of-hours support and a responsive service to all of our supported housing accommodation across the organisation. Once the daytime team have left site, they hand over to SMART. They switch over the ward and call system to off-site, and this enables us to support service users via the Tunstall unit. We can respond to give face-to-face support if needed. We can support emergency services if there's any incidents, carry out safe and well checks, and visit and respond to any customers who are either locked out of their property or need any additional support. So over the last 10 years, we've moved with the market really, and we've kind of looked outward as an organisation in how we can support other services and looked at other streams of business. So over the last 10 years, we've managed mental health helplines. We support people with enduring mental health needs, their families and carers. We use our PNC system to link an ID number to each of our callers. This helps identify our regular callers, limits vulnerable callers having to repeat their history. There's a full audit trail, which helps to look at call reasons, ensuring that we can be proactively referred into other services for support. We have a clear audit trail for a variety of KPIs. Those vary dependent on commissioners' requests and contractual obligations. So these are around call volumes, call trends, repeat callers, and also outcomes. Just going to give you a bit of overview of each of our helpline. So we've got a CKW mental health helpline, which is a 24-hour mental health helpline. We offer confidential help advice to anybody registered with a GP in Calderdale, Kirklees, Wakefield, Leeds and Barnsley. The service has been designed to support people who are experienced or are at risk of developing mental health problems, are experiencing mental health distress, family or carers. We respond to urgent concerns and operate within a recovery model, ensuring callers benefit from effective intervention in line with local mental health support pathways. We liaise with the single point of access teams, which are the crisis teams, emergency services and adult social care, ensuring we've got a multi-agency approach. So our North Yorkshire Mental Health Helpline, we've worked in partnership with North Yorkshire County Council for the last 6 years, offering a mental health support helpline via its framework service. The council offers face-to-face services and we deliver emotional support, reassurance and wellbeing calls, as well as providing a referral route to adult social care team. We're a confidential and anonymous service which is available to anyone registered with a North Yorkshire GP who are experiencing mental health and distress, as well as their carers and family members. Our Wellness in Mind helpline is for a Nottingham City based helpline. So we work with Nottingham City Council to provide residents with emotional support, reassurance, a listening ear. We can refer into their wellbeing hub where face-to-face and proactive support, practical support can be given. So just talking about outcomes now. So at the moment, we're currently running on PNC 8.2, which provides us with a platform for the delivery of more integrated care and support services, working across the housing, care and health landscape to support person-centred care. We act as a central point for relevant information about individuals to be stored, accessed and used to provide a more complete picture of their needs within GDPR guidelines. Data on their health, housing, care requirements and any risks can be reviewed to help build a person-centred support plan, enabling services to meet specific needs and outcomes. We can also work with the MDT team as well around care plans and to look at what other support a customer is actually getting outside of our service. The system means operators have all the relevant information about each caller displayed clearly on screen every time we get a call, ensuring appropriate action can be taken quickly. This gives the customer a more personalised individual service. This really supports NCHA's vision, NCHA's mission, values and vision. As well as offering management reporting on KPI indicators, PNC can be interrogated to highlight areas of need geographically or demographically to aid the development of strategies to target resources where they are needed most. So just to talk through some call volumes, more so with this year, because I don't think any of us ever predicted this time last year what we would have gone through this year. So if we look at January this year, you know, our inbound calls, we had 15,622, 916 of those from our mental health helplines. So as you can see, as we've gone through sort of the COVID, sort of getting through to March, April, started to rise in June, July, getting into August, where we was hitting 18,743 and 4,500 of those were from our helplines. So our response to COVID, as I just said, the last 10 months have just been, I don't think any of us have ever thought the work that would have gone into what we have done over the last 10 months. So our inbound call volumes have increased by 60%, and that is solely because of COVID-19. particularly from people experiencing with mental health issues. There's a lot of isolation, a lot of NHS services that have gone online or just telephone. So there are a lot of people out there that aren't seeing people every day. From December 2019 to March 2020, we've seen contracts consistently perform at between 160 and 108 above contracted hours. As the NHS was forced to suspend face-to-face clinics and therapeutic services, many people were unsure of how to access support, and Smart have provided a gateway to other services, in many cases avoiding ambulance call-outs and presenting at A&E. Like everybody else, if you've got any questions at the end, I'll be happy to answer them.
Thank you so much, Sarah.
Thank you.
That was a really nice example of how you've kind of used the technology, but you've really pivoted your whole model of delivery of care to embrace new groups and new areas, which probably set you up really well for when COVID did unexpectedly happen.
Yes, and I think because our service is 24-hour, and especially around the helplines, and also the PNC system that we use, it's for us, it's a really great tool to accommodate just rolling out new services like helplines. And I think commissioners were faced with, especially targeting people with mental health issues around COVID, about making sure that people had got a service to access 24 hours a day. So I think we did that really well, because at the beginning of COVID, I had to move my team over to our learning and development department. So we faced a few challenges, but I think the outcome of it is, and I guess everybody's in the same boat. It just shows you what you can do, and when you have to kind of look outside of the box, how to carry on delivering your services.
Absolutely. Right. So we're up to 20 questions. So I think we should probably crack on with those as fast as possible. Now, it wasn't the first question, but it's probably one of the easiest ones I can answer, and Sarah can chime in too. Is somebody asked what PNC means? It almost doesn't matter what it means. It's a legacy name from Tunstall years ago, and I think there's an urban myth in Tunstall that it's the name of the founder's dog, but it's not. It stands for Piper Network something or other. I should probably know that, but actually what it does is much more important, which is it's the monitoring software that the monitoring centres, the alarm receiving centres, use to manage all of their calls. Yeah, it's been around for a long time, and it's constantly evolved, and it's used in a huge amount of the monitoring centres across the UK. So I don't know if you want to add anything to that, Sarah.
When I talk about PNC system, they always think we've got the police database, because the police database is PNC. But for us, I think the beauty for us, and which we've seen as our service has grown over the last 10 years, especially around sort of person-centered. As soon as somebody calls, you've got all my frontline operators have got all the details of that person on one screen, and I think that's really valuable when you're trying to coordinate emergency services or somebody that's vulnerable, whether it be mental health, domestic violence, helplines. They don't want to have to keep telling and repeating their story. And my frontline guys have got a history, an audit trail of the conversations that the customers had with other frontline staff. So while they're talking, they can get a bit of a picture of what's happened over the last week or the last month.
Perfect. So I hope that's answered your question. Just looking at the other questions that we're getting. So right at the top there was a anonymous person asking, I'm looking forward to seeing where digital technology can be integrated into sheltered and extra care housing schemes to allow reliable transmission of information on the new digital telephone infrastructure. That's a really hot topic at the moment, because a lot of housing associations and a lot of housing schemes still run old analog equipment, and actually the infrastructure in their housing is also analog. So what we're working on in Tunstall, what we're looking to do in the new year is to allow people to be able to be able to transform that analog message, that analog data, into something that will talk a digital language. Now, I'm not even going to pretend to be an expert in the whole telephony and digital transformation stuff, so you're going to get a very simple answer from me. But basically, we're looking at something that will help the analog system talk to the digital system, and therefore allow legacy systems to carry on until there is a chance for an upgrade to a full digital system. And I think the idea of a full digital system does offer so much more in terms of the other products that you can integrate into digital technologies, that I'm pretty sure that most schemes ultimately will want to go down that route, because what they'll be able to provide their residents and the residents' families, and what they'll be able to see from a data perspective, will be so much more enhanced with digital solutions. What the challenge is at the minute, we've got to get everybody as a kind of over that line in a way that doesn't bankrupt the country, basically, because I'm pretty sure trying to rip out copper wiring for most of the housing schemes in the UK is not going to happen in the next 6 months or even the next couple of years. So there needs to be a smart transition from analog to digital in a way that actually we can afford as society. And then I think the second question was around what's being done to promote interoperability, because that's a major challenge to the industry. It absolutely is. So there are industry standards around protocols, digital protocols, for how all of this stuff talks to each other, and we implement those with those standard protocols. The challenge we've got is it's a bit like teaching somebody a new language. So everybody might speak English with the new protocol, but people might speak English with a different dialect. So it's making sure that everybody understands the same. So that's the way somebody explained it to me. We're all speaking English under this new protocol, but somebody's speaking it with a thick Scottish accent from the far north, and then you've got somebody from Cornwall speaking with a very, very different accent in the southwest, and we need to make sure that everybody understands the same language. So that's what most of the industry are working on at the moment. And if you're a regular visitor to the TSA, then they're a big promoter of interoperability, and it will happen, because no one company is going to make every solution that's needed to support telehealth and telecare. So we're going to have systems that talk to each other. In terms of one person's asked around activities of daily living. Can you please give examples of this working? I don't know if Sarah, you would like to answer that, if from what you guys do in Nottingham.
Sorry, could you repeat the question?
So that would be, I love the idea of activities of daily living. Can you give some examples of where it's working?
Around with the technology?
Yeah.
So I guess around daily living, with across our care and support industry, we have various teams that go into each individual projects and accommodation that arrange that in the day. That some of them, sorry, I'm a bit. I don't think I fully understand the question. Sorry, could you just?
No, that's okay. I can give you an example from how we've used it with some customers, and then it might make a bit more sense.
Okay, yeah. Okay.
So some of the activities of daily living solutions that we partner with in Tunstall. So we partner with companies who make particular sensors. So when some of our customers are going in to assess somebody for telecare, rather than park somebody in their house for 6 weeks to watch what they do, we deploy sensors around the home, and the sensors record things like how often they're turning the taps on, how often they're opening and closing doors, whether they're opening the fridge or not, and then we get a pattern of behaviour. So we get a baseline measurement on what somebody's normal pattern is. So that's really at the minute used to decide what kind of level of telecare that person would need. Now, what we want to be doing in the future is putting even cleverer passive monitoring devices into people's homes that just sit there in the corner and monitor all those things and establish a baseline, but then are also capable of sending an alarm information if that baseline changes. So if somebody's normal pattern was to open the fridge door 8 times a day, I'm sure if anybody's got teenage children, it's probably more than that. But if they were opening the fridge regularly and then suddenly that changed and it was only twice, then that information would then potentially be sent to an alarm receiving centre who could use their proactive calling capability to check up. So that's certainly how we've got customers using it. I hope that answers the question.
I think the other thing to add for me, Zilla, is that some of this is also to look at it in relation to other aspects of support that enable people to live independently through activities of daily living. So Joe may have examples of where it links into reablement or rehabilitation for people who've had long-term conditions, and access to support services from OTs for community equipment, disabled facilities grants as well. So while we talk interoperability around the technology, we also need to think sometimes around the interoperability around that person-centeredness that Sarah was talking about as well.
Exactly. If we just move on, Rosie Dyke from Dorset Council has asked, how do we keep our personal information secure for patients and in confidence? So Joanna, I don't know if you want to answer that from your experience perspective.
I guess we work closely with Tunstall, and obviously the devices were password protected, and clearly the admission avoidance access points at Castle Hill were only accessible to them. So we've met with our information governance leads and our GDPR, but obviously we had no other information regarding that person. We would access the medical record via our agreed route anyway. So actually it was only the observations that we could view. So there wasn't anything identifiable in terms of that person's history, but certainly the devices have two-factor authentication, and they go via a defined route to an agreed group of staff that manage them within our admission avoidance team. So to be honest, it feels really, really safe, and it wasn't anything that any of the homes felt wasn't something they were already doing, with reading observations out over the phone, and also giving information with regards to supporting remote assessment of the care home residents with GPs and with admission avoidance staff. And in a way it felt safer, because I think when you're reading something out, there's always that margin that something is potentially going to be misheard. It's that translation, it's not quite being understood, where if anything it felt safer from a patient point of view, a resident point of view, because actually the actual device is sending the reading to the tablet, and then the clinician can view it in real time. So if anything, nobody really expressed any concerns or issues, and we were confident about how we handle that data.
And just from my perspective, everything is stored in the Microsoft Azure cloud. That's the hosting where we store all the information from ICP, which is bound by huge levels of security. And then we have this 2-level authentication. So it's only approved members of staff who can access the portal, and there's a double layer of security around that. So it is very much a real consideration, and it's one of the things that I think the NHS has always been quite rightly concerned about when deploying solutions like this. So another question around does Tunstall Connect only work with Tunstall Response? At the moment, yes, but we do hope that in the future we'll be able to make it talk to other, certainly PNC ARCs that run the Tunstall software. I think it might be more of a challenge to get it to talk to other systems because of the way it's built as an app. But certainly the hope is that we'll be able to in the future make it available to other monitoring centres besides Tunstall Response. Okay, maybe this one's one for you, Jeremy, to help me answer. Is there any feature at home to be prioritised that would enhance the care-ready features mentioned on the happy principles? And which technologies would be most important to promote independence?
Yeah, that's a really good question. The actual happy design principles set out 10 particular standards, and they're fairly loose, to be honest, on technology. And that's partly because technology has evolved so rapidly since the first happy report back in 2008. However, one of the things people may be interested to know is that we've secured some funding from the Dunhill Medical Trust to build on the happy design principles and come up with a technology technology to aid our ageing population, which we've loosely called the TAPI design principles. So one of the things really, this is both to reflect on the fact that we are moving from analog to digital, but also how do we make sure in terms of care readiness, how do we look both at the digital aspects to support care and to enable people to be care and supported at home, but also how do we design, so things like off-site manufacturing or modern methods of construction, the way the bricks and mortar, the sort of looking at the structure of buildings, how can we make sure that they are accessible and adaptable to take into account technology as well. So this is a really important question and something that we will be sort of focusing on through a chair, Professor Roy Sandbeck, who's going to lead on this, who actually is also on the TSA board. So it links in quite neatly with the question that was posted.
Thank you. A question for Joanna was around staff training, and so remote patient monitoring may reduce the cost of visits, but does require additional skills from care staff. Does that mean we increase their salaries were increased, or in remuneration in that way? And how do we assume they were trained?
Do you want my personal view or my professional view on that one? I felt very passionately about the care homes at the start of the pandemic and throughout, really, and it became my big drive, really, and working with those staff with what they faced, and some of them moved in, and I think remote monitoring was one of the things that actually helped them. The rest of the things we asked them to do, I mean, we saw in Bolton 30% of our COVID-related deaths in care homes, and yet there was so much emphasis on, you know, it did get better, didn't it, about clapping for carers, but so much emphasis on the impact on hospitals. But my background is community nursing, and I felt very strongly that we were going in with district nursing teams with PPE, trying to train the carers in end of life care. You know, it felt like the Tunstall work was something we could give them almost to empower them to keep people out. They were really worried about staff coming in and the impact. They knew they had things in place, and they were limiting all of their contacts outside of work, but then they would get another case in, you know, and we couldn't account because we'd stopped visiting. So if anything, I felt like Tunstall was something that we gave them and said, look, you know, we're trying to help you, we want to train you, but I have my personal views about what we pay them, and I'll reserve that, but hopefully it will be recognised and picked up that they were working at a much higher level, really, and caring for people, you know, phenomenally, I have to say, you know, at a much higher level than I think anybody realises sometimes. And the relationships they had with those carers really complemented the Tunstall, because they could really pick up those soft signs. You know, they were really seeing that deterioration in that person who was more confused, who was going to the toilet a bit more, long before their SATs deteriorated. It was really interesting. But so no, I didn't get them any more money. I'd have liked to have done, but what I did try and do was replicate the same support that the hospital staff got psychologically, and just keeping in contact with them, really. But I'm sure money would have been nice.
Always, and I think from our perspective, obviously, that's not something we can really comment on as Tunstall. But what we are trying to do is to make sure we know that when in the past, when technological solutions have been deployed, there hasn't really been enough focus on the people who have to use it day to day, and making sure they're comfortable and trained properly, so that it's not a stress. It shouldn't be something that gives them additional stress. It should be something that helps them in their daily job and makes it easier. So we're putting a huge amount of effort now into training and education, and making sure that when we're putting systems in place, we're giving better user experience to the people who have to use it day to day, but also to the patients as well. So there's big focus on how do we drive patient engagement, and how do we help the patients understand. That will be different whether it's My Mobile, which will be out in the community, versus something in a care home. But I think it's equally important that we get lots of feedback from patients about what they'd like to see and how they'd like us to develop the patient-facing end of the software, and also the user interface, to make it as simple and as easy and painless as possible. Because technology should make your life better. It shouldn't make your life more stressful. Somebody did ask whether we provide the provide the handsets and the Android devices, or whether people use their own. We can do either. So in the case of Bolton, we did provide the equipment, but we have had customers who've deployed My Mobile to teenagers, for example, with eating disorders, where the teenagers, a lot of them have used their own devices and they've just used the app, and they've been monitored remotely that way. So it's the nice thing, the beauty of it is it's quite flexible, and we say it's condition agnostic. So it's not just something that you would use for diabetes or heart failure. You can actually monitor pretty much any condition that you can collect vital signs for or collect information around the patient's well-being. And somebody asked also, what are the options for remote and rural communities where telehealth is not an option due to lack of local teams to respond to people's needs? That's a really interesting one, because it's one of the areas we've been exploring with some of our academic partners who are particularly focused on how you reach rural communities. So in theory, as video conferencing gets better, and there's safer adoption of technologies like Attend Anywhere and Teams and potentially Zoom, although we were discussing earlier how Zoom's not allowed in a lot of institutions for security reasons. But as those things get better, then there's an argument to say you might actually be able to reach more people in a rural community through telehealth and telemonitoring and remote patient monitoring than you would with community nursing teams, and you might be able to manage a bigger cohort more effectively because you can do that remotely, and hopefully the patients will become more interested and involved in managing their own conditions as well.
Zilla, you raise a really interesting observation there, and Jennifer, who I think is based in Scotland from memory, there are some real significant challenges. And back in 2018, Lord Best had an inquiry looking at rural housing issues, and one of the things they came through quite strongly was the amount of digital exclusion that exists, both because of the fact that utilities aren't always in place, and in fact broadband was probably the fourth most important thing after transport, social care and health in terms of having access to broadband, and there was a lot of digital exclusion around that, but also the role of, and I think Joanne mentioned it, some of the pathfinders around sort of ambulance and other sort of enhanced care services that could be developed in partnership with other parts of public services as well to provide more integrated community hubs in some localities. So I know the Happy Inquiry, for that particular inquiry, visited places like North Yorkshire and Shropshire, where in England there were some really good examples of that rural aspect.
Thank you. This is a question for Joanne around, do you think that the COVID-19 vaccine deployment will affect on the longer term use of deployment of this kind of technology?
I think it's too early to say yet, isn't it? And I think why I suppose I'm saying yes and no is that yes, of course, we won't see the volume of acutely unwell patients, residents that we saw then, and sadly that we're seeing to some degree now. But there is still massive potential, of keeping people from care homes well and out of hospital, and the need to do that, I think, for any long-term condition or infection. I think it enabled us to identify those people who were unwell, not just because of COVID, who potentially did have a urinary tract infection or an emerging chest infection. So I'd like to think it had a value, as it would for anybody with any kind of long-term condition, whether they're in their own home or they're in residential home or they're in supported living, if I'm honest. But I think, if I'm honest, it's too early to tell. And I think at the minute I'm just doing everything, as many of us are that work in health and care, with a month on month, and we wait to see what January brings, really, in terms of now, sadly, a predicted potential third wave. But again, so I'd like to say it will have a long-term value. But again, I think everybody's engagement has been very heightened to change and recorded because of the situation we're in. And I think there has been a lot of negative press surrounding care homes, as we know, nationally. So I think there's been a real willingness to work with us, and I'd like to think that will be maintained, but only time will tell.
I mean, obviously we hope there'll be a continued interest in it, particularly in moving towards more proactive versions of telecare, but also real engagement in telehealth. That's always been a challenge, actually, to crack the NHS with telehealth for most companies, whereas COVID's now kind of opened the doors for that. And what we probably need to do now as industry is actually start looking at what does good remote patient monitoring look like in terms of guidelines and standards, and generating clinical data. So as well, I think that's somebody said, you know, will it be funded after COVID, when this has all died down and the vaccines rolled out? Will anybody care about paying for remote patient monitoring? So I think it's down to industry to work with our customers to build cost effectiveness models to prove that it is cost effective and it does work. And I think there's stuff out there. A lot of it's quite old, and the technology's advanced a lot since the trials from 10 years ago around the whole system demonstrator model. But I think there's definitely an opportunity to revisit that, and an appetite to do the right kinds of studies in the right patient cohorts to show that it's not just cost effective, but it improves quality of life as well. And then an observation from one participant who said that they didn't think this webinar was so much around person-centered support. It's more around what currently is done by telecare, and I think that's a fair observation. I think what we're trying to do as an industry, and certainly Tunstall's very keen on moving to much more person-centered care. So part of that is the digital enablement. So we have to manage that switch from analog to digital, and it's not going to be easy, particularly in rural communities where digital's not going to be a slam dunk and going to be that easy. But we have to be able to move to that digital world, because then you will be able to move to much more person-centered care. And on a small side, what we're doing in Tunstall is we're looking at things like with ICP, with our patient monitoring software, how do we do things like introduce gamification? So how do we get patients really engaged in their own healthcare by rewarding them, or giving them a kind of gamification dopamine reward mechanism for playing with their health apps, and also by partnering with organizations who can then help us push educational content and wellbeing content out to them, so that they can be, if somebody's got diabetes, they can be accessing webinars or accessing websites and apps that help them manage their diet and diabetes and weight and blood sugar and all that kind of stuff. So it's very much in our mind that we need to be doing more of that. I hope that's kind of addressed that point to some extent. So yeah, we're not quite there yet. We haven't realised the Tunstall cognitive care vision, and there's a long way to go, but I think that we're starting to take the right steps. I think that's most.
Can I just come in briefly?
Yeah,
Tony
sure.
Clark, I see, has asked a question about how to support people with wellbeing. I'm not sure we've responded to that directly. But there have been a number of examples. The LIN has populated our website with. We have an A to Z on loneliness and isolation, and examples of how housing operators and organisations have supported people, both in terms of looking at their physical health and wellbeing, but also their mental health and wellbeing. So things from buddying right through to WhatsApp groups and Facebook events, through to online arts and recreation as well. There are a number of different sort of mechanisms out there, and again, I think do contact us, and we can sort of signpost to what other organisations have done with regard to that as well during this time.
Okay, so I think we're kind of getting towards the end of the session. There was one more question I think I kind of found around general, where do you think this technology could help people live independently? Hopefully we've covered some of that in some of the answers we've given, but certainly the way telecare is developing across Europe, if you look at where we are in the UK, is very much, we're still in the reactive telecare space. To be fair, there are exceptions, like the team in Nottingham. There are other customers and other teams who are really advancing telecare in the UK, and certainly the TSA are very involved in looking at more proactive and models of telecare. There are other countries that are way ahead of us. So in Spain, proactive telecare is the standard of care now, and it's also proactive and personalised telecare. So instead of having a reactive model, they're using things like activities of daily living, assessments, and on-site assessments with individuals to risk stratify them. So we're risk stratifying the service users in their home, and then they're adopting proactive telecare models around that. So somebody who's particularly high risk would get a very intense level of proactive telecare, which would mean somebody was proactively engaging with them regularly to make sure they're okay. And whereas patients who are less at risk would have a less intense telecare regime, and it's been shown to dramatically reduce the number of ambulance calls out and the number of emergencies in A&E. It's extended the time by about 8.5 months on average that people can stay at home before they go into care. And actually, there is some evidence that it actually also might have helped contribute to an decreased mortality, and people living longer. So there's models in other countries that we can definitely learn from, and the way the monitoring software, certainly our monitoring software, I think in general the market's going is to really introduce those clever risk stratification tools so that we can start delivering that model of care. But a bit like remote patient monitoring, the tools alone are not going to do it. It's going to be around industry, working with organisations like TSA and ABHI, and working with progressive customers to actually change the behaviours and change the culture and make it happen.
And on that, Zilla, you may be interested to know that the UKRI and Innovate UK, as part of their healthy ageing programme, want to extend 5 years additional healthy life. Now, I know that Paul Burstow and I are on the advisory board for that. So again, we want to make sure that both the tech elements, but also the housing elements are really integrated in, and some of the pathfinders they'll be developing and hopefully maturing into the marketplace in the coming years.
Perfect. That's and it's quite an exciting time, because when you bring all of that together and you look at housing and the influence that has on people's quality of life and health, and you look at how technology can help, and I think you look at how people are becoming a lot more empowered and aware now. I think we're actually going to see technology probably being. I think the world's going to shift away from older, more vulnerable people with alarms in their homes to younger, fitter people embracing technology earlier and helping them live that extra 5 years independently, without being, having a much more active and higher quality of life.
Absolutely.
Okay, well, I just wanted, I guess it's probably down to me to wrap up before I hand over to Jeremy, and thank both our speakers. I think personally, I'm always humbled by all of the work that people in the community do to support, whether it's in care homes or support people who with mental health issues or patients who are vulnerable. So it's always heartening to hear that when it works, and it works really well, and it's what gets me out of bed in the morning to think that Tunstall have managed to contribute to that in some way and support these teams who do all this great work. So that I just want to thank both of the speakers for a really comprehensive overview and for bringing so much passion to what they do. And again, thank everybody for taking their time out on a Wednesday afternoon to join us, and Housing LIN for giving us this opportunity to host this event.
Well, thank you, Zil, and we look forward to carrying on the conversation. And as Lois has posted, we've got a few more sessions this week, but I know next year we'll be doing a lot more based on the TAPI principles as well. And we look forward to engaging with you and partners. So on behalf of the LIN, thank you all as well.
Fantastic, thank you.